Now we have another roundtable with the two presenters, Cristina Sanchez and Mara Gordon, also moderated by Correjon from Illegal Hill. Also, Landaverde, he's the chief of the oncology service of the Mexico Hospital here, professor of oncology of the University of Costa Rica, and part of the Central Committee of Pharmacotherapy of the Costa Rican Social Security System. We also have the participation of Andrea Cartín. Dr. Cartín is a palliative medicine doctor at Hospital Mexico.
So first, how accurately do you believe the dosing observations in animals can transfer to humans? In other words, will the same dose a mouse gets to reduce tumor growth work in a human, either more or less? I'm sure some are wondering about that.
I'm going to start the answer because I'm the one working at the lowest level, meaning animals. And my answer to your question would be definitely not. We cannot compare or even translate animal doses into human doses. The metabolism of rodents and human beings is completely different. So the answer to your question is definitely not. Please don't look at our papers, and I mean not only of my group, and I mean basic research papers. Don't look at them, calculate what a mouse weighs, and do the translation, because it doesn't work like that.
I did that. I translated what a mouse weighs and then tried to show how it absolutely has no correlation to humans. It's important that we understand that they work on the cells, but when it comes to dosing, dosing is about metabolism, dosing is about age, dosing is an individual. And even if you have 10 people that are the same age with the same diagnosis, they may have 10 different doses, and so be aware of that as well.
Speaking on animals, real quick, Dr. Sanchez, what, if any, were the negative results shown in animals when given high doses of THC? Any negative effects from the THC?
If they have ever been found, you mean in the animal studies? Not that I'm aware of. Is it true that it's true that there are some few studies, if you compare them with those showing anti-proliferative effects? There are a couple of studies showing proliferation stimulating effects in cell cultures, not in animal models of cancer. And those are probably related to the hormonal status of the cells, more specifically the hormone receptors that these cells express. But the vast majority of the papers, scientific papers that are out, show just what I showed today.
Awesome. So why have formal clinical trials? Oh, were you going to say something? Go ahead.
I just have a question for you about the breast cancer tumor cells, because we have now the triple negative, HER2 positive, so we can divide to different kind of tumors. So I think that triple negative tumors, they have more angiogenesis, and I think it's a very important topic that you talked about it a little. And I think that it's very important to know if cannabis can produce something in those kind of tumors.
Well, I think it can. Actually, there are preclinical evidence showing that basically every kind of breast cancer can benefit from cannabinoids. We work on HER2-positive cancer, breast cancer, and in these models it's pretty obvious that we have anti-proliferative responses, anti-tumor responses. But there are evidence from other groups, Sean McAllister among others, where they work with triple-negative breast cancer cell lines and animal models, and also with hormone receptor positive breast tumors. Although I have to say that these are the ones that respond, not more, less than the others. But they do respond. I mean, it's not probably the best scenario, but for the other two, and triple-negative breast cancer is a challenge in the clinic right now because there's no targeted therapy for them. They have to receive standard chemotherapy, which is very toxic. So for this population in particular, I think it would be very useful.
So you mentioned how in Israel there's going to be a trial using pure CBD as a single agent for the treatment of solid tumors. Do you believe that single isolated cannabinoids do have utility in the treatment of cancer in humans?
That's for me. Good question first. I was expecting that. Yeah, let me tell you, so far we don't have prospective trials showing the real benefit of cannabinoids against chemotherapy. You know, if we compare both, we don't have exactly clinical trials showing that, I mean phase 3 trials. But probably there is one effect of cannabinoids when you combine with chemotherapy. We don't know that so far. We don't have that data. We have the only published information that we have is the one that you showed. Is the only one showing that there is a benefit of using cannabinoids in glioblastoma. But in breast cancer, lung cancer, pancreatic, head and neck, we don't have enough data to support the use of that. So I think it is not good to recommend to use the cannabinoids as a first line of treatment. I do prefer to recommend what is standard. And what is standard? Chemotherapy, radiation, surgery to treat the cancer. So because it means that we can give an opportunity to the patient to have a response and overall survival benefit. So I know that we have to study more the use of cannabis. It's urgent to start studies on phase 3 conditions or moment in order to know exactly what is the real role of cannabis as first line.
I want to say that the one thing I want to say though is even if we don't tell anybody to not go with standard Western treatment. We would, first of all, that would be irresponsible. And we would probably make enemies of the whole medical community while we're trying to invite them into the discussion. What we say is that the cannabis and the cannabinoids will help to make the Western, the chemotherapies more effective while protecting the person's healthy cells from being destroyed. So it helps to, so because it's actually doesn't work directly on the cancer, it works on the receptor sites that then work on creating this chemical cascade. It doesn't really matter which type of cancer it is in your body because the same chemical cascade is going to take effect. Regardless. And if nothing else, it's going to help with the side effects of chemotherapy and radiation. It's going to be a neuroprotectant for radiation, and it's going to, of course, we don't have 10-year studies, 20-year studies yet, but we see a lot less recurrences, which people oftentimes, the chemotherapy will get rid of the cancer, they're cancer-free, and then 5 years later they have a different cancer as a result. And we're seeing less of that reoccurrence and reintroduction of cancers.
What needs to be done to get cannabis accepted as a part of integrative oncology?
First of all, we know that our patients are using it, and it helps, but we need like the law, and we need to know the dosage. We need to know where they're buying it. Because I've seen patients that have good results with it, at least from the palliative care perspective. But we need to do more. I need to know. My patients doesn't tell me where they buy it, which is in the components that are missing, and well, I not recommend it at first. But if they are using it, well, they can keep on doing it because they have the benefits, but we need a lot to do. We don't have any trials. We don't have permission for our government to do trials. So that's at least one point of view that it has to be done in some point.
In Spanish, we say, I'm going to get into a garden. It means I'm going to be politically incorrect.
There is my group in Spain has designed, in collaboration with a group of oncologists in one of the biggest public hospitals in Madrid. There is a protocol already designed, and we just need the money. So it's really a pity, but in most cases, it's just a question of money. We don't have more clinical trials because nobody wants to support these clinical trials. So this trial cannot start because we need $200,000. That's all it takes. But we don't have that amount of money. Public institutions in Spain don't give that amount of money to do trials, and we depend on pharmaceutical companies. So we don't want to go with the pharmaceutical companies. And there is this group in the Netherlands that is doing something that is called the Cannabis Medical Bike Tour. They go through Europe biking and collecting money for doing research. And part of their money has been given to our lab to try to start this trial. So I think this is just an example of what is the situation in most cases. So we depend on the pharmaceutical companies. That's the reality.
Do you have any ideas on how or why cannabinoids can selectively kill cancer cells and distinguish between cancer cells and healthy cells?
Well, we have some clues, but we don't have the final answer to that. And part of the group is actually trying to find out what is the difference. It's not the expression of cannabinoid receptors, because healthy, let's call them healthy cells, they do express cannabinoid receptors in most cases. Well, with CB2 is a little bit different, because the expression in healthy tissues is restricted to the immune system, but when you have a disease, when you have a pathology, CB2 levels rise up. But it's not the expression of cannabinoid receptors. We know that there is something else that we are trying to find out, but we don't have the answer yet.
Yeah, I have a question regarding the immune suppression produced by cannabis in terms of the long-term side effect could be the recurrence of tumors?
No, we have never seen that, and actually there are trials in the past that has been performed where it has been very obvious that chronic use of cannabis has not produced any immunosuppressive effects. There were studies in AIDS patients, for example, chronic cannabis users, and they saw no, how do you say, a worsening of their disease or anything like that. So I wouldn't expect that.
One thing I want to mention there, because I don't know how it is here, but in the United States, or at least in California, if you're on a transplant list, if you need an organ transplant, and you have THC in your system, you are automatically excluded from being eligible to have an organ transplanted. And yet we have had numerous patients who have been, or organ transplant patients who have done very, very well, and only when they were required to go off their medicine did they then decline. The THC can sometimes be the difference between success or failure and rejection of a tumor, and don't understand why, don't know anything about the mechanism, but just know that they do better on it, and they seem to have their counts are better. Of course, you have to be careful about how they take them in order to not have too much going through the liver on the THC, but it's like it doesn't hurt the immune system, and yet keeps people from rejecting foreign. So it's once again, it's a selective in a way that we don't yet know the mechanism.
And that's odd. How are pediatric and adult cancer patients treated differently with cannabis? Is the endocannabinoid system different in a pediatric patient than in an adult?
Well, when we treat a pediatric cancer patient, we ordinarily are dealing with one problem, and that is the child is a beautiful, wonderful, healthy child that happens to have cancer that we're dealing with. And we can concentrate on that and just, and because they don't get uptight if they have a feeling, they don't have any of these issues, we can really dose them very high and very effectively, very quickly. When you're dealing with adults, they're going to need, like we talked about before, because of the metabolism and the age they're in processes that we don't yet understand, they require a far less of a dose to accomplish the same thing. But in addition, when you're dealing with adults that have cancers, rarely do you have somebody who's basically a really, really healthy person who also has the cancer. There's always other things going on with them that you have to treat in addition or with well. That's why it's important to do a full health history and know what's going on with somebody when you start your treatment protocols.
How important do you believe the terpenes are to the overall anti-cancer effect of whole plant cannabis extracts?
I think the terpenes are extremely important. There, like I said before, there's almost 500 or whatever that we know of terpenes at this point. Our lab, I believe, tests for 32 or 36 of them. And they each have their own benefits, as well as the fact that the way that they act, like, for example, the myrcene, creating greater absorption of the THC, which increases the bioavailability, of course. You have other issues that are involved in other terpenes as well, that when they act along with the cannabis, they have greater effect. We have I often say I do not use OG Kush for cancer, full stop, period. And I don't do it because of the terpene profile, not because of the level of THC and not the level of the CBD, but it's because of the particular set of terpenes that are traditionally found in a standardized OG Kush are not those that are beneficial as much for treating cancer. And for some reason, they just don't work as well. You can have the exact same amount of THC and the exact same amount of CBD, but if you have these different terpenes, there is in fact a different outcome.
So how important do you all believe nutrition is to the overall effectiveness of cannabis extracts against cancer?
Nutrition is absolutely important, especially like if you're dealing with, let's stick with cancer for a minute here. When you're dealing with cancer, you have to eliminate all sugars and all things that metabolize into glucose in your body because of, if anyone's familiar with something known as the Warburg effect and what happened with glucose on the cancer cells. It's like, I like to describe it as it's putting a Kevlar vest. It's putting a protective vest around the cancer cells and protects them from all the treatments that you that you do. So you're somebody that's eating sugar at the same time that they're taking anti-cancer drugs are basically putting a roadblock in the way of the success of the medicines. So that's the first thing. The other thing is to not have good nutrition, not to have the proper fats, and to have the proper fibers and to create an alkaline environment in your body, you're going to keep the same environment that was present that allowed the cannabis to develop in the first place. So if you don't change what was going on in the body to begin with, you're just going to be in a continuous state of catch-up with returning them to health and then keeping them healthy. We recommend traditionally the Mediterranean diet, which is high in fats and pretty simple for most people. And then you just want to get your alkaline levels up high enough that it's an environment where cancer cells cannot survive.
Well, at least in my experience, I see that nutrition is a very important part of the patient with cancer and for his family or her family. So it helps. And when they go to the consult and say, oh, I'm eating, and they don't have the money to use other kind of pharmaceutics, well, at least they have the feeling that, or at least they are eating, so it's really good. But like Dr. Landaverde said, we don't have really good studies that says that it's better than all the protocols that we use. It has less side effects than the ones that they are established.
Chemotherapy can produce some changes in the taste, and the cannabis can improve that. Yeah.
Final question to any of your physicians. As a physician, did you always look at cannabis as a medicine? And if not, what was the deciding factor? And then follow up, were you taught anything about cannabis or the endocannabinoid system in medical school? Thank you.
Well, for me, cannabis is a medication for sure. And we don't know exactly when is the best moment to deliver, to give the cannabis. We don't know exactly what is the best way to give it. If that it could be inhaled or oils. I don't know exactly, and the dosage is not clear, even though you said the age is important. But We don't know exactly. We're familiar with dosage, with kilograms and everything like that, milligrams, but not with the dosage. But I think it's a drug that we have to explore more. It has a lot of benefits that we are not using. A lot of patients are not having the benefit of the drug so far, and I think they do have this benefit. So I can tell you just one case in my clinical practice. I had a 65-year-old male with a hepatocellular carcinoma, and he was treated initially with sorafenib, that is the upfront treatment. And unfortunately, after 4 months of treatment, the tumor progressed, and then I switched to another chemotherapy, and I put it on capecitabine and oxaliplatin. And he just had one cycle of chemotherapy, and then he has a lot of side effects. So he decided to stop the chemotherapy. It was, I think, a very clever option. So he decided to start marijuana. So the thing is that he started with that, and after 6 months, the disease was well controlled. So that is one case. I'm not saying it will work in all hepatocellular carcinomas or breast cancer or not, but I think that there is a potential drug there in clinical practice that we can use. But again, my first recommendation was the sorafenib, or the standard treatment. I decided to use in third line.
And what did they teach you about cannabis in medical school, if anything?
They don't teach that in medical school. Nothing about it. Yeah.
At least in the palliative care program, in the postgraduate program, we are trying to study more about it. So in the pre-grade, we don't have in the medical education, but in the postgraduate, when you want to be a specialist, we're trying to include that because our patients are using it. So, we don't recommend it as a first line, but we have to know what is it.
See cannabis as a medicine all your life, or
No, it was when I was in my clinical practice and when my patients told me. Because I think it's very important that you know your patients and you have the confidence that they tell you, I'm not using methadone or opioids because I don't like them, but I'm using this drug. So it's important for us to know that. And I see in patients that they don't have nausea for chemo, they have a good appetite, they are feeling well. So at least for my palliative patients, it's working. But I don't know what the dosage that is given. I don't know any other side effects, if they have like cardiac effects or something like that. But at least they have a quality of life.